Hi, welcome to You and Your Health. I'm your host, David Bertone. Today's show is dedicated to a specific injury to the knee that has become more commonplace in terms of injuries to athletes and non-athletes. We're talking about the anterior cruciate ligament of the knee, better known as the ACL. We're finding that as athletes get a little bit more advanced in their sports and non-athletes in their chosen field of work, with certain traumatic events can develop a tear of this very important stabilizing ligament. As advances in technology and surgical skills have progressed, along with more evidence in terms of the rehabilitation process, we're able to get the athlete and the non-athlete back to their chosen sport or work much faster. We're lucky to have today one of the legends in the area of orthopedic surgeon. Dr. Harry Bade has been practicing over 30 years and specializes in the area of anterior cruciate ligament surgery. He is the founder of Professional Orthopedic Associates with offices in Tinton Falls, Toms River, and Freehold. Dr. Bade, welcome to the show.
Thank you.
All right, we're going to talk about the ACL today, and it's in the news quite often with various athletes. I'm sure you've seen hundreds, if not thousands, of athletes over the years with this type of injury. Tell us a little bit about your background and the type of surgeries and athletes that you see that may have this particular problem.
Well, as you have said, I am an orthopedic surgeon. An orthopedic surgeon specializes in the musculoskeletal system. Early on in my training, being an athlete, I became interested in specializing in sports-related injuries. I was lucky enough to train at the Roosevelt Hospital in New York, where Dr. Parks, James Parks, was the Met physician. Also, Dr. Patterson was the physician for the Rangers and the Knicks. Mm-hmm. So immediately as I started in my clinical practice, being an intern and resident, I am dealing with sports-related injuries. Later I went to the hospital for special surgery. There we were involved with the USGA tennis, but also the New York Giants. And I was involved with Russell Warren, mm-hmm. who is the team physician for the Giants.
Great.
And that's sort of, it's continued. I'm still sort of a consultant. I will see people that are related to the Giant family. Mm-hmm. I do not see the athletes. They go still to Dr. Warren. Mm-hmm. But with that, when I came to New Jersey, as you said, 30 years ago, I started my practice and I started to be more involved in sports-related injuries. Mr. Walt Reeser, who is the athletic trainer and the athletic director at Rumson Fairhaven, called me during my first year of practice, and I went over and met him, and that's when it sort of all started. I started to be the physician for Rumson Fairhaven, and over the years, my practice of 7 other orthopedic surgeons that are also all dealing with sports-related injuries have sort of accumulated about 20 of the high schools in the area, where we go to all the football games and we sort of hold clinics for them. I'm also the team physician for Monmouth University, for Georgian Court University, and I have been for the USBL, which is the Professional Basketball League, and the Jersey Stallions.
Great.
So again, I'm an orthopedic surgeon, but we specialize, the practice, all of us specialize in sports-type injuries.
Okay. So over that time period, obviously you've seen hundreds, like I said, if not thousands of injuries to the knee. We're going to talk specifically about the anterior cruciate ligament. Can you just give us a little background about why is this ligament so important, maybe a little basic overview of the anatomy as to what we're looking at here?
Well, again, if you look at things, in sports-related injuries, the number one joint injured is the ankle, but the knee is probably more important.
Okay.
And with bigger, stronger, faster athletes, both men and women, and really more people participating in sports, they need their knees. And the anterior cruciate ligament is the sort of the major stabilizer of the knee. Now, if we can look at, you have this will help things. But we're looking at a knee here, and if you can take a look, the femoral condyles here, the femur, this is the femur of the thigh bone, they're not even. All right? So when the knee goes through flexion and extension, if it is a fixed fulcrum, the femur will rotate back off of the tibia. Watch that, see that?
Mm-hmm.
So what does the anterior cruciate ligament do? It is the stabilizer that as the knee flexes, it pulls the femur forward or the tibia backwards and makes the femur slide and stay centralized on the tibial plateau.
We're looking at this structure right here, correct?
The structure is the structure in the front right here. And the structure goes from the anterior aspect of the tibia to the posterior aspect of the femur. So that's its main job. It also helps both stability this way. So what it's doing is, with the quadriceps, hamstrings, calf muscles, all the muscles that motor it, it's holding the knee together as these muscles work to propel the athlete forward or backwards.
Okay. What is the common mechanism of injury to this particular ligament? What normally happens when someone injures their ACL?
There's three mechanisms really. It's basically a deacceleration injury. Again, acceleration gets you going, and it's just like in a car. Think about deacceleration gets you going. All of a sudden, you put on the brakes, right? What are you thrown forward dramatically? So it's a deacceleration injury where when you land or your foot is planted, you now have to flex the knee to control yourself, but you also have rotation or torque, twist. So it's deacceleration, slowing down, flexion, and torque. Mm-hmm. This can occur when you're running fast towards the sideline, suddenly planting your foot, or a lot of times it's landing from a jump. Mm-hmm. The other mechanism, less common, is a sudden hyperextension injury, where you'll tear more of the proximal aspect or the upper aspect off the femur. The deacceleration injury is more of a central injury that's spiral, it rotates through it. Mm-hmm. But once the ACL has flexibility, so it can sort of stretch out about 15% of its length, but once it goes past that stretch, it now starts to rupture or tear, and it goes quickly. It's like a millisecond, it ruptures.
Mm-hmm. And what is the classic sign? I mean, some athletes will mention a pop. They'll hear a pop, or they'll feel a pop, and they'll feel immediate swelling. Is that something that's very common?
They'll again, perfect. They will tell you pop, snap, crack. They can feel it. Mm-hmm. Go. And again, here you have a tremendous amount of tensile force. And if you just think of a little short rope, pull the rope, break the rope, you hear it. It's audible. It cracks, snaps, mm-hmm. as it ruptures or breaks. Mm-hmm. Okay. Same thing we see with Achilles tendons. They hear it. Okay. But as soon as it happens, then they'll tell you, my knee shifts out of place. Mm-hmm. So again, the ligament that's holding two bones together now tears. It's failed. It now allows the femur and the tibia to shift apart. And this is what they say. Shift, we call it pivot shift, mm-hmm. Then they fall down, and a lot of times they'll say it shifts back, or all of a sudden on the ground, it doesn't feel too bad, because the knee wants to be back in position. Mm-hmm. So it falls back into that position. And depending upon if it's only an ACL injury, they won't have much pain. A complete tear tears the pain fibers in the ligament, so there are no real fibers under tension, pain fibers under tension, mm-hmm. that are now sending messages of pain. So just an isolated tear doesn't hurt much, but a tear that goes beyond that and hurts other structures, capsule, other ligaments, menisci, that hurts a lot more. Afterwards, when you see the patient, a lot of times, again, they'll have a lot of pain or they won't have pain. Mm-hmm. Some can get up and walk to the sidelines, some can't. But it gets better over a short period of time, then it starts to swell.
Okay. We're seeing now more in the sports. I know I see more in my practice the female athlete, mm-hmm. that is sustaining these injuries. What is your theory, or what does the research say is the reason for this increase?
Well, it's true, okay? And I think it's becoming more evident, as you say in your practice, because more females are not just participating in sports, they're high-level sports. And there are more sports. I mean, recently it's lacrosse, and now we have ice hockey.
Yep.
So beyond, field hockey and soccer and tennis and badminton and basketball and softball, I mean the female athlete is out there, and there's the same number of female athletes out there as there are males. And the only variation out of all this is football.
Yeah. From a biomechanical standpoint, what are some of the reasons?
Okay, we'll get to that. So now research has gone, why do females have more injuries? And they do. Female soccer players have twice the number of injuries, softball players twice, 3 times, basketball players 4 times. So research has now gone into that, and it's multifactorial. It's a lot of different things, okay? Number one, if you look at the anatomy, let's look at anatomy first, wider pelvis, all right? So a wider pelvis means that the angle of the femurs to the tibia at the knee is increased. Okay, so we have a greater, what we call Q angle, it's quadriceps angle, and what does that do? It causes more torque or twist at the knees. Okay, also anatomically, they've talked about hormones. Women, girls go through their menstrual periods, and a certain time during the menstrual periods, there's an increased estrogens. Increased estrogens cause increased flexibility. So women have more flexibility. Okay, that's just not in their normal tissues, i.e. the ligaments and tendons. They'll have increased flexibility or give in the muscles themselves. So there's more give there. Female athletes are weaker than males. I mean, it's just they just cannot build up the strength that a male can. Why? What makes muscle? Androgens. That's male hormones. Males have more androgens than females. The female ACL is smaller. The cross-sectional area is smaller, therefore it is weaker. And some of the female athletes are getting fairly good size. They're the same size as male athletes. The notch where the anterior cruciate ligament rests inside the knee for a female is smaller. Therefore, with certain twists, that notch can impinge or become, can be pressing on the anterior cruciate ligament. And anything, if you think about it, if you want to break something, if you hit it in the vulnerable area with the right angle, you can start the process of tearing or breaking. Also, we're getting things. Research has gone into now, again, looking at the female athlete. The female athlete, Lily, runs, jumps, and does things differently than the male athlete. They have a tendency to keep their knees straighter, okay? Their hips are therefore straighter, and their ankles are therefore not as flexed. So they're a little bit more upright. They find that causes more problems with function. Okay?
Is that primarily when they're landing and
when
jumping?
They're landing, or even when they're trying to, change direction quickly.
Okay. They
don't squat down or get down. And again, a lot of athletes, when they're going to change direction, they're flexed more than 90 degrees. Okay? The female reaction to sudden, stress on the knee is slower than a male's by about a millisecond. So their muscles do not begin to function as fast as a male's. Also, the hamstrings are percentage-wise weaker than the quadriceps muscles. So the quadriceps, therefore, are stronger than the hamstrings, and yet the hamstrings are the ones that hold the tibia back and support the anterior cruciate ligament.
So it is a very complex process, and there's a lot of factors, as you said, multifactorial.
A lot of factors.
When it comes to ACL injuries. When we come back after the break, we're going to hear more from Dr. Bade as to what you do once the injury does occur and what the prognosis is for recovery to your prior level of function.
Childproof caps don't work forever. Prescription drug abuse can kill. Talk to your teen.
Welcome back to You and Your Health. I'm your host, David Bertone. Today our guest is Dr. Harry Bade, an orthopedic surgeon, and we're talking about injuries to the anterior cruciate ligament of the knee. We heard in the first half of the show about the mechanism of injury and some of the risk factors. Now we're going to talk about what happens after the injury occurs. Dr. Bade, again, welcome to the show.
Thank you again.
So once the injury does occur, what is the typical examination like, and then what happens afterwards?
Again, typical examination, you first start off with questions. You know, when you get the right answers, you think anterior cruciate ligament injury. Okay. The test that's done, it's called the anterior Lockman maneuver. And what you do is you will take your hands, one hand will be placed on the thigh, one hand is on the tibia. The anterior cruciate ligament holds the tibia to the femur, so you're going to do just the opposite. You're going to pull the tibia forward and the femur backwards, push it backwards. You do that, and once you've done enough of them, you feel it. It slides beyond. You will first do the non-injured side, so the athlete gets a feel of what you're going to do. Mm-hmm. So you talk to them. You usually talk to it with their trainer there, and then you do the test, and it's quick.
It's classic.
You feel it. Mm-hmm. It's classic. If it's torn, it's torn.
And then what happens after that? You made the decision that it's torn. I assume you have a discussion at that point as to surgery or not. What is the follow-up?
Well, after that, well, the first thing then is to take care of the acute situation. What's happened? There's going to be swelling in it. You want to keep swelling down, okay? You want to then evaluate the knee properly. An X-ray is done at some point, followed by an MRI. Now, the MRI is not necessarily there to say, is the anterior cruciate ligament injured or not, because you already know that. I want to look at, is there cartilage injury, and is there a meniscus, the discs that are in there, or is there articular cartilage injury? 1/3 of the time there is meniscal injury, and to a lesser extent there's articular cartilage injury, because these are factors that you have to know, because it tells you about the prognosis. If you fix the anterior cruciate ligament, you have to either fix these other structures, you have to fix them somehow. Mm-hmm. So for the next 3 weeks, the most important thing is you get them to go to physical therapy. They need to go to physical therapy. They need to move the knee, obtain normal motion in it, reduce swelling, mm-hmm. and reduce this what we call arthrofibrosis. If the knee has been injured, the knee will immediately go through a physiologic change to repair itself. Mm-hmm. So it'll send these pluripotential cells to the knee and the surrounding structures to produce healing, which is scarring. So what you want to do is get past that into the reparative phase of things, because if you rush in too fast, then you get scarring, and then scarring from the surgery. So that knee, when it goes to surgery to have reconstruction, should be almost 100% except for the anterior cruciate ligament injury. So there is a lot of preparation with physical therapy before having the surgery, and during that period of time you educate the injured athlete and the family of what's going to happen, and they also will see a therapist that's going to treat them afterwards, so they get comfortable with the therapist.
Now, this happens to be one of my areas of expertise, and I've treated hundreds of injured athletes with ACL reconstructions, and quite often they're scared and they're nervous and they don't know what to expect, and you know, we both do education in terms of trying to let them know what's going to happen. What I've found is most of the times these athletes will actually be better athletes after the whole process, because they've gone through such an extensive program of relearning how to move. And they really get excited about that because that's something for them to look forward to. Now, let's get on to the surgical component of it. What is it that you do in basic terms to repair this structure?
Right. I would say 99% of surgeries are done arthroscopically, minimal invasive surgery. And at surgery, we'll again look at the knee here, what you do is you have two portals. You make 2 half-inch incisions on both sides of the patellar tendon, and through that you're able to look throughout the entire knee. Now, the surgery is done by, well, number one, you have to remove the torn anterior cruciate ligament, so that's debrided, and now you have to reconstruct it. You reconstruct it. There are many different ways to reconstruct it, but the basis is to create a bone tunnel. There's a little tunnel placed through the tibia that then enters the tibial plateau at the insertion. So you make a 1 centimeter or a ½ inch tunnel, and then through that tunnel, you also make a tunnel up into the femur. So all of that surgery is now done through a small 1 to 1½ incision on the tibia. Now, you then take a graft, you run a reconstructor within a graft. It can be an autograft from the patient, which means you can use some hamstrings. These are hamstrings over here tendons, or you can use portion of the patellar tendon or quadriceps tendon, or you can use an allograft, which is from another human being that has died, and certain parts of that parts of that person have been processed. Again, patellar tendon, quadriceps tendon, hamstrings, Achilles tendon, tibialis anterior posterior tendons from the ankle. Okay? So we have tissue to reconstruct it with. And what you do is you then place that tissue through those drill holes, okay, and then fixate the tissue in the drill holes. The bone now will then heal down to the tissue. That tissue is generally stronger than the anterior cruciate ligament that they had initially, and it heals. If you use allografts from other people, okay, it's better to go, I'm going to say male because they're stronger, like we've already talked about. Okay? And it's better to go cryopreserved, which means that there's a certain freezing process that doesn't change the fibers. They remain strong.
Now, the gold standard had been the patella tendon. Has that changed at all in the research?
It's not as common. I would say by saying the gold standard, with 95% of them all were done with the patellar tendon, which included bone off the patella and the anterior tubercle here, so I had bone on both sides. I would say it's probably down to 50% because we have these other structures that probably work just as well.
Yeah, and I found that the patient has less post-surgical pain when you don't take the patella tendon, and less risk factors for developing tendonitis when you don't use that. Is that correct?
Correct. I mean, yes, correct. You have to use a larger incision if you want to remove that, but there are also intra-articular things that during your surgery that you would do to stop that. Right. And again, in my experience, you work very hard not to have the athlete have patellar tendon pain after anterior cruciate ligament surgery.
Great. Okay, so now the surgery is done. We've learned about the different options. What happens in the post-op phase, and what goes on there?
Post-operative phase, what we've gotten to is, again, first thing is stabilize the knee and minimize pain. So a lot of the athletes, there is a femoral nerve block done that then numbs up the thigh and numbs up the front of the knee. Less pain means less swelling. Okay? Also means the total accumulation of pain into the brain. If you can minimize the pain in the beginning, then the brain has less pain totally, and the pathways of pain are less. Less pain means the athlete now can get to rehab faster. So what we do is we send them to rehab quickly. At surgery, the graft is positioned. It's what we call isometric, so the knee can be brought through a full range of motion that's observed by the surgeon without making the graft too tight or too loose. So I can start motion. You want to get your motion back immediately, so therapy starts 3, 4, 5 days after surgery. They're in therapy with the therapist that they had before, a friend, and that friend starts to take care of them again, and they start to get their motion back. And we find that there's better healing with motion in the knee. So motion is first. We want to maintain full extension, get flexion, let the athlete do it, let the therapist help them along, and then shortly afterwards, as we get motion back, we start on strengthening.
I find with these patients, I mean, the first 4 to 6 weeks are relatively boring, but they're important because we want to prevent problems later on. Once you get past that 6-week point, then we really start having fun with them and we start moving. Is that correct? Is that kind of the time frame that you look at from more advanced activities?
I would say, I would have to say yes again. I mean, you're a physical therapist. You're the expert in physical therapy.
From a healing standpoint.
Yeah, in the beginning, a little stiffy, a little painful. You know, they got to get through that. But it does get a lot more fun with the different activities and all the new sort of physical therapy training that the patient does. It's boring to sit there stretch to get your motion back, and then when you start the strengthening exercise, not a lot are done. But then you're right. Like I say, maybe not at 4 weeks, but at 6 weeks, we start to do some different things that they begin to enjoy.
Yeah, one of the most important things is retraining the joint and teaching it how to learn again and how to respond quickly in space. We call that proprioception.
Correct.
But then we get more advanced in the process. We're going to get them back to their sport, agility and jumping and all that stuff. How important is that?
Well, again, both things. What they start doing is the two basic therapy modalities is just what you said, proprioception. It's getting the knee to start to work again to control itself. You know, it's time and space. You know, you're trying to hold it together, and it's the simple. I'll just for your simple, as you know, it's just standing on the knee alone. Mm-hmm. Now stand on the knee with your eyes closed. Okay. Now stand on the knee with your eyes open, but on an uneven surface. Now do it with your eyes closed. Now do it on an uneven surface that starts changing, and eyes closed. These are the games that, and they see that. Mm-hmm. Next is, when you get past that, is plyometrics. Okay, and what we really want to do is we want to do we want both muscles to work at the same time, the quadriceps and the hamstrings to work together. So plyometrics is these little jumping programs. You start to jump up, but then you have to jump down. Mm-hmm. You have to jump left, right, back, front, and then you start all of these games. And what are you doing? You're working else at other times just on strength, but now you're working on function, which is the knee, and that's what protects the knee. You got to get the knee now to really work quickly to, again, another situation that might injure it.
Oh, that's an important lead into the last segment, which is prevention. What can athletes do and coaches do to help prevent these problems if it's possible?
Well, it's already started. There are prevention programs going on now, and again, it's for the female athletes. Okay, the female athlete, what we just said, when they land and they get these injuries, their knees are straighter. Well, if I can get that knee flexed more, okay, and again, it's ankle, knee, hip. If I can get all to flex more, it's under better control. So there's this saying, put the hip over the knee, over the ankle. So you got to get the female athlete down in a more flexed posture. Okay? When they land, they have a tendency, because their hips are wider, to rotate in. No, if you rotate in, you're now twisting the knee more. Get them to land, keeping their knees straight. Okay? Mm-hmm. Also, you start to then do these exercises with them where the quadriceps and the hamstrings are working together right now. So again, these exercises are done, plyometrics is done, proprioception is done with them, and lo and behold, looking at large groups, there's a dramatic decrease in the female ACL injuries, which is terrific.
Absolutely. Great. Well, Dr. Bade, thank you so much for joining us today. You've heard from Dr. Harry Bade about ACL injuries in the athlete. Again, thanks for joining us here on You and Your Health. I'm your host, David Bertone. We'll see you next time.